introductions. Okay. Okay. Introduction.
Okay. Hi, my name is Shirley Miller. I'm an occupational therapist here at Insight Hospital, and I've been practicing in my profession for about 30 years. And my specialty area is outpatient, but I've also worked in acute care setting, rehab, home care. So those are the things that I've done in my 30 years. And I'm also lymphedema certified. I'm a lymphedema therapist. So I specialize in swelling of an extremity, whether it's an arm or a leg. So I'm going to turn it over to Julian.
Okay, my name is Julian Allison. I am an occupational therapist who's been practicing for now 18 years. My specialty is stroke. I also have a lot of background in spinal cord and other neurological disorders. I'm also certified in kinesio taping, which is therapeutic taping. My background is teaching. I've had over 30 plus uh, students who are fieldwork students and occupational therapists, as well as I was a former special ed teacher prior to becoming an OT.
And I'll add to that too. I specialize in outpatient treatment too. So I've treated several hand patients with diagnosis of carpal tunnel release, tendon injuries, extensor flexor tendon injuries, also fractures of the finger, phalanx fractures, also shoulders, work with rotator cuff tears, various diagnoses in outpatient.
Okay.
Mhm.
All right. Let's see. Question, let me say number 4.
Mhm.
So what type of clients or patients do we typically work with in our respective specialty areas?
Okay.
Uh,
Well, for you, because
uh,
I spoke of some of
right,
mine in
right.
outpatient.
Okay. For me,
Mhm.
I here at Insight, I do acute care rehab. So I go
Mhm.
on the general medical floors, telemetry, ICU, ED, and basically I receive orders from doctors, and the
Mhm.
orders can vary from, debility to stroke to laminectomies to, all things in between. So typically, my goal is to get in, assess, see potential therapy needs, and then make my recommendations over to the doctor. So, since this is not a level 1 trauma center, we don't really get, gunshot wounds or stab wounds unless there's like a past history of it.
Mhm.
However, we have to basically have some knowledge of that as well too. So. Mhm.
Mhm. And I just want to kind of piggyback on, I mentioned I'm a certified lymphedema therapist, and I see patients who have lymphedema as a result of breast cancer. And we do a lot of education to patients, self massage or manual lymphatic drainage, and also just teaching them how to manage the lymphedema themselves at home, and also giving them resources and different supply companies to order like a sleeve or a glove for their hands, or for men and women if it's lymphedema in the lower extremity, stockings or pantyhose, actually, depending on how far the swelling is in the extremity.
Okay, good.
Okay.
Okay. Shirley, how did you choose your specific area of occupational therapy and what motivates you to pursue it?
Okay. I love working with outpatients for one. And how did I choose my profession?
How did your particular area?
My particular area
Of occupational therapy.
Okay.
So,
Yeah. Um, I love, as I stated, working with outpatients, and I love doing hand therapy and also making and fabricating splints and braces for patients. That has always been an interest of mine, and also working with the various different hand injuries and diagnosis. And I'm really passionate about what I do.
And for me, stroke is the
Hmm.
area that I really do find endearing to me because, again, I think a lot of us have had family or friends who've been impacted by the diagnosis of stroke. So as a result, I did get a certification as a certified rehab stroke specialist, and it's
Hmm.
just because, again, the
Hmm.
interest and knowing the impact it can have on a person who has it and is dealing with it, and family wanting to get information on how their family can potentially be rehabbed or how they can progress. So that was a very strong area for me to decide to go into, and I'm very motivated by it because it affects us. It affects many communities, not just the
Absolutely.
communities here in Bronzeville and
Hmm.
Chinatown, but all around Chicago and all around the world. So
Hmm.
yes, that's a very big motivator for me and the reason why I decided to pursue that certification. Okay,
Hmm.
Shirley, can you give me some common challenges faced by occupational therapists in your specialty area and how you overcome them?
Hmm. I'm gonna have to think about that. Some of the challenges that I had. I'll let you.
Okay, so
I'll roll that question back over to you
okay,
while I
well,
think about
right.
some.
Well, the biggest challenge,
Hmm.
particularly with dealing
Hmm.
with stroke patients and
Hmm.
or common ones, motivation. Sometimes
Hmm.
you have patients who they're affected by their stroke where they become depressed. And it's hard to get them out of that depression and stuff like that. So I think as a team, that's the reason why we talk with the doctors, we talk with the nurses to make sure that maybe antidepressant can be used in order to, to kind of lessen the effects of it. So getting them motivated, getting them
Hmm.
to want to
Hmm.
participate, and also learn about like what therapy can do to enhance or alter their life so that they can return back to being functional again. Because as I tell my patients, life doesn't stop because of disability. It
That
really
is so
doesn't.
true.
It just
So
you
true.
absolutely have to turn a negative into a positive
Hmm.
and stuff. So that's a big challenge as well sometimes. And also, family can also be a little bit of a challenge too, because sometimes there might be, you know, a little bickering here and there as far as who's going to take care of grandmother, who's going to take care of granddad,
Hmm.
where should granddad go post the hospital? Should he go to a nursing home? Should he come home? Do we who should they come home with? Are there stairs there? So basically coming up with that disposition to say where is the best place for someone's loved ones to go, because sometimes they don't want their loved one to go to a rehab center. Sometimes
Hmm.
you make your recommendation and they're like, no, we want him to come home. But if home is stairs and home is having people in and out versus that constant assist level and people
Hmm.
actually who learn how to assist them right,
Hmm.
and yeah, we sometimes hard decisions have to be made, but I'm very respectful of family decisions and family dynamics. So that's some of the challenges as far as my specialty area. Shirley,
Okay.
what about yours? You have time to process?
Yes, I had time to process the question that you asked.
Okay.
Yes, the challenges I have found with outpatients, a lot of times they feel that they don't have to do their exercises at home, or some of them just don't do their exercises at home. And I find myself constantly encouraging them to do their exercises because a lot of times I tell them what we do here in therapy and what you do at home helps you make the progress you want to see and the progress that I want to see. And a lot of times, the challengings for some of my lymphedema, which has been a major thing with lymphedema patients, is a lot of them don't like wearing the bandages when we have to bandage extremity, because for one reason it's a little uncomfortable, and it's also an appearance thing, and self-consciously it bothers them and they feel like someone is looking at them and they have to always explain why their arm is bandaged or the leg is bandaged. So following our recommendations is a little challenging for some of our lymphedema patients, and bandages, and also doing the self-care that they need to do to keep the extremity to a point where it's keep the swelling down. Just to be honest, to manage the swelling. In order to manage the swelling, you have to do the self-care, proper self-care, a proper bandaging, and do your exercises. And sometimes that's challenging for a lot of patients.
Correct. Shirley, can you discuss the importance of interdisciplinary collaborations in the various specialty areas of occupational therapy and share some examples of successful collaborations? So, and I'll start first. Okay. I'll start with this.
You can start with that, but I was thinking about rehab.
Okay,
go ahead.
Okay, go ahead.
No, go ahead.
Okay.
I'll let you start.
So collaboration is so important. We did at one point, we had a bariatric patient here in acute care, and she was 600 plus pounds, and she needs to be turned, and she needs to be cleaned. So nurses, CNAs, PTs, we all collaborated on finding the best possible way to turn her, because naturally everybody wants to come in and they have their ideas and stuff like that, which is good. But to hear that one voice to make this very patient friendly, so the woman didn't feel like she was just being thrown around and tossed on her side, we wanted to make sure that we incorporated, her feelings, as well as let people know or let others know, like, hey, you know what, we're not just going to take this woman just throw around, but actually work collaboratively in order to find the best position for her so that we could get the sheets underneath her, get her clean, inspect her skin, and make sure that her pain and she had bad lymphedema in her legs as well, that she was positioned correctly so she could tolerate being moved. So that was probably one of the biggest and most satisfying situations where I said, oh, Insight works really good together. We, when you have your nurses and CNAs and we're all on the same accord and everybody's listening, and we're also taking in what the patient, what her preferences are as far as movement and stuff like that. And everybody's not just trying to just pick her up and just throw her around. So I think she really appreciated that. Yeah,
I think teamwork is a big part of what our department does too. In OT, we work well as a team.
Oh yeah.
And especially for achieving the patient's goal. And it's important to have interdisciplinary teamwork, and that's what Julian is talking about or discussing, where the nurses as well as the physical therapists and the occupational therapists work together to help that patient. Okay, I have a question for you, Julian. Can you share any advice for new occupational therapists entering the field, particularly in your specialty areas?
Okay, definitely you have to have compassion. If you're not compassionate and you absolutely see this person and you can't feel like if you have this feeling where you can't help someone in their time of need, this isn't a profession for you. So, and that's my advice, is always to, when you see a patient, particularly somebody who might not even look like you, who might be a different nationality, might be a different religious order of you, or whatever the case is, it's still a human being. And you have to have that compassion to say, hey, listen, I'm going to help my fellow man, I'm going to help my fellow woman, because this is the way that life is helping others. So my advice is to come in, be whatever, preconceived notions you might have had in the past, or it might have been heard that you've heard on the news, leave them at the door. When you're in this profession, you definitely have to make sure that you're compassionate first. The knowledge and all those things that comes with, learning how to be a therapist and stuff like that. But you absolutely need to be able to see that person as a person. If they're in wet blankets, wet stuff, let's get them out. What can we do in order to make this person feel, whole again? So, yeah, so that's probably my biggest.
And I'll just piggyback on that. My advice to new grads and students regarding that is, like you say, be passionate. But my first advice would be, like, first of all, make sure you're a people person, that you enjoy working with people. Before you choose the profession that you want to go into or pursue, make sure that you enjoy and that you're passionate about working with people with different disabilities, different illnesses, different injuries, and then pick what area. I would say research, just like I'm gonna just say what I did. I was a nursing major, believe it or not, Julian. I was a nursing major. Now, this is in 91. This is many moons ago. I was a nursing major, and I decided, maybe in my second or third year, I wanted to switch my profession. And thank God I had an advisor who told me, Shirley, I explained to him, I want to stay in the healthcare profession, but I no longer want to pursue nursing, as a career. So it was early enough for me to look at other professions. But what I did, I volunteered actually at Mercy Hospital, to be exact, to decide whether or not I wanted to become a OT or a PT.
Nice.
And that's how I made my decision. So my advice to someone who wants to enter our profession is to educate yourself, read about it, and also to volunteer. If you can volunteer at certain hospitals that still does volunteer hours, and that way you can make your decision to choose the profession. But I agree with Julian. You have to be passionate about what you do, especially this profession.
Correct.
Correct.
Okay.
And
go ahead. Okay.
what I was going to say, and also find out what schools, what universities have your profession once you choose the profession that you're interested in.
Okay. Gotcha. Okay. Shirley, can you share some success stories from your specialty area that highlight the positive impact of occupational therapy on your clients? A success story.
A success story. Let me think about. I did have a lymphedema patient who she used to, and I mean, this was many years ago. She was actually a caterer, and she used to bake cakes, and she would have to stand up for long hours. Well, I got her to the point where she had it's different stages of lymphedema in terms of the swelling. And the stage 3 is about here, kind of looking like a tree trunk type swelling. At stage 3, stage 4. And I got it to a point at the end of the session, I was able to order pantyhose for her. She was able to stand more, walk better. After the management, the manual lymphatic drainage, the bandaging, the self-care, and felt better, because that's what it's about. Correct. You feeling better about yourself, and being able to do the things, the day-to-day activities you enjoy.
Gotcha. Sure.
Okay. So I had a lymphedema patient who she definitely improved in terms of her function and doing her self care and being able to continue to do her work duties.
Mhm.
And also hand patients too, being able to work, return to work. I've had several success stories where patients that were able to return to work and do some
Mhm.
of the things that they used to.
Sure. And for
Okay.
me, for one of
Mm-hmm.
my certification, the kinesio taping, I've
Mm-hmm.
always was kind of a doubting Thomas as far as how the therapeutic tape worked.
Mm-hmm.
Now, when I
Oh, I
did,
love it.
oh, I love it too now. And but I had to have one of those successful moments or one of those
Mm-hmm.
aha moments that says, oh, this does work.
Mm-hmm.
So, so basically, had a stroke patient who had about a 2-inch shoulder subluxation. So basically, with the shoulder subluxation, the humeral head uh, removes or becomes displaced from the humeral from the GH fossa. So uh, me learning from my kinesio tape experience taught me
Mm-hmm.
how to basically reset the arm or reposition the arm so it was mechanically protected and replaced back into the humeral head. So Jay's fossa was placed back in there and to put a stretch on there that allowed the shoulder to always
Mm-hmm.
get proprioceptive input back in, keyed in with um, um, E-stem. So I put E-stem on the supraspinatus and the posterior deltoid. So the
Mm-hmm.
combination of the kinesio taping with the E-stem allowed that 2-inch shoulder subluxation to slowly get to a point where the arm was at least almost like maybe half finger subluxation. And then, of
Mm-hmm.
course, it took the education part too. So you have to educate the nurses as well as educate my fellow PTs about like when they're ambulating this patient to make sure that a sling was put on this patient so to prevent the arm from just hanging, but also and then telling the CNAs when they do turn the patient never to grab the arm and pull at the arm and stuff like that. But the therapy part, as far as the constant, you know, taping along with the E-stem,
Mm-hmm.
helped to reduce that subluxation by a full finger and a half. So and that was really,
Mm-hmm.
really, really good. So okay,
Good, 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 good.
okay.
Yeah, we do a lot. A lot of people don't understand what occupational therapy does and our profession, but it's about helping patients to be able to do their day-to-day activities, no matter whether they suffer a illness or disability, getting them to a point of independence. And that's the goal, whether it's right,
Yeah,
Julian,
correct,
whether
correct,
it's
correct,
their day activities,
correct,
work related,
correct, correct. Oh yeah.
hmm
Okay.
school, home.
Okay.
Hmm.
Okay. Um, Shirley, how has the landscape of occupational therapy evolved in recent years, and what do you think the future holds for the profession? So, and Shirley can speak to this because she's seen over 30 years. So, how has it from the days you started to even what
Hmm.
you're looking at now? How has it evolved? What have you seen?
Oh, I've seen a lot of changes, and especially in the type of techniques we perform as occupational therapists compared to in the 90s.
Mm-hmm.
Because I started, at a VA hospital.
Mm, okay.
That was my first job. I worked, and I didn't mention this, I worked at several hospitals, I believe four, five to be exact.
Nice.
Well,
Nice.
yeah.
Mm-hmm.
So I, as well as you,
Yeah,
Julian, because
yeah,
I know you,
okay.
several.
Mm-hmm.
And at the VA, I was actually privy to a lot of equipment
Mm-hmm.
that you don't have in the private, as I call this, the private sector now.
Mm-hmm.
Definitely with hand therapy, things like when we use splitting material,
Mm-hmm.
we actually had a machine to actually cut the material.
Yep.
Yeah.
Okay.
And also make splints. But I see changes in terms of our treatments. We did a lot of activities in the past in terms of getting patients achieving their goals, things like needle,
Mm-hmm. Oh yeah.
threading,
Oh yeah.
mosaic tiles and all of that.
Mm-hmm.
Now we're using different forms of treatment activities,
Mm-hmm.
and we're using modalities, just like you say, the
Mm-hmm.
e-stem,
Mm-hmm.
the also using the ultrasound, things like that for patients, especially with our hand patients as
Mm-hmm.
well as the
Correct.
shoulder.
Correct.
Mm-hmm.
Yeah.
Mm-hmm. Yeah.
And what do you think about the future of OT? How do you
I
envision?
think we're in good hands. I think we're in good hands, and I think, as you know, as an occupational therapist, we have to always take educational courses. So we're constantly learning.
Mm-hmm.
So there's always new techniques,
Mm-hmm.
new technology out there to improve our abilities to treat patients with whatever disability,
Mm-hmm.
injury, and also stroke. There's new techniques with stroke patients.
Correct.
So I think it's constantly evolving.
Correct.
Hmm.
Correct. Correct.
Hmm.
And same thing in mine. I don't have as long of a history with OT as far as Shirley does, but
Hmm.
just in my time, just as far as the innovative things, because I always think it's kind of eclectic. I think that there's something good with the old mixed in with something with the new,
Hmm.
because again, some of the old ways of occupational therapy, particularly with a lot of, you know, hand stitching stuff and fabricating stuff.
Absolutely.
Nowadays, companies have gotten rich, already having these things
Hmm.
prefabbed, already done, so
Absolutely.
as a result,
That's.
healthcare has evolved
Hmm.
too, and occupational therapy has gotten on board with this. So a lot of the stuff that was done in the early 80s and the 90s, you know, occupational therapy doesn't have to go and hand do these things like they used to. So now, and the big thing is technology. I mean,
Hmm.
technology has advanced so that, nowadays
Absolutely.
you can find a program on a tablet to deal with visual spatial disorders. You can find, stuff on, with an app to describe how,
Hmm.
strokes evolve.
Hmm.
So, and that's a good learning tool not only for therapists but also for family members. So I
Absolutely.
think that the fact that the information highway has opened up so much not only for society, but it also has opened up for therapy, and particularly occupational therapy. So
Hmm.
yeah, so I think that that's the big thing, and I think that the sky is the limit for the new generation. I have a goddaughter now
Absolutely.
who graduated from OT school,
Hmm.
and her thinking at a young age of 26, she's 26 now,
Hmm.
you know, the younger generation, they're so social media savvy.
Tell me, yes,
So
that
so
is
they
so
know. So
true.
now these kids, they can go on social media and they can look up stuff. They can look up stuff, how to cook, how to make a
Hmm.
splint, how to do this, that, and the other. So
Hmm.
that
So true.
information, I just hope that the new younger therapists, they realize what they have and they're able to curtail it into very
Hmm.
treatment friendly things without losing the compassion. Because
Absolutely.
sometimes, all this information is really good, but I want them to hold on to that compassion. The
Hmm.
fact that, that your goal is to help the person and not be so caught into technology. So
Hmm.
that's what I hope and pray for the future of this field, is that they keep a good appreciation for the old school stuff too.
Hmm.
So don't just be,
Absolutely.
let me go see, let me go on
Hmm.
and Google
Hmm.
and see how to do this. No, but to actually think for themselves. So
Oh, absolutely.
yeah, okay. Um,
Absolutely.
let's see. Oh,
Oh, I was going to
go, go,
piggyback
go,
on
go,
that
go,
too,
go ahead.
because I have a niece too,
Mm-hmm,
who's actually pursuing occupational therapy as
mm-hmm,
a profession. And I always give her advice too about, make sure she study and know what she's interested in, but she's also doing some things that we didn't do.
Yeah.
Geospatial,
Yeah. Oh my goodness.
somehow it relates to how it relates to
Oh
occupational
wow.
therapy.
Okay.
And
Okay.
so she's a little advanced in terms of learning more. So you're right. And that geospatial stuff is
Hmm.
technology.
Yeah. Yeah.
And
That's what it is.
you know, when she was explaining to me how that could relate to occupational therapy in different ways, I was kind of blown away. But yeah, our profession is in good hands,
Yeah.
you know,
Okay.
and it's going to continue to grow, I believe.
Okay. Okay. How do you approach setting and achieving goals with your clients in your respective specialty areas?
Okay. I'm going to speak about some of my hand patients.
Hmm.
When I evaluate my patients, I first find out what things they having difficulty with.
Hmm.
You know, what areas they need to be something as simple as being able to hold a steering wheel and drive when you can't even make a fist
Hmm.
is important to patients when they can't even bend their
Correct.
fingers. So being able to return to work, some of them may say, I want to be able to do my
Hmm.
job. I want
Hmm.
to be able to hold the mop.
Hmm.
I want to be able to sweep.
Correct.
You know, little simple things like that that we take for granted,
Hmm.
you know, mean a lot to patients who no longer have the ability to do that.
Correct.
Hmm.
Correct.
So, in achieving their goals, I write my goals based on their deficit areas, the
Hmm.
things that are difficult for them, that's meaning to them, the
Hmm.
things that they want to return to doing. Things like opening a tight jar,
Hmm.
holding a grocery bag, you know, carrying their grocery,
Hmm.
lifting things, opening the refrigerator, opening the microwave, things like that that we take for granted. Those are the day-to-day activities, which we call independent
Hmm.
ADLs,
Correct.
independent IADLs,
Hmm.
which is their daily living activities, independent activities of daily living.
Correct.
So that's how I base my goals based on their deficit areas
Hmm.
and what they're passionate about
Hmm.
returning
Correct.
to do.
Correct.
Hmm.
So
What
as
about you?
a evaluating therapist, it's my
Hmm.
goal to actually conduct a semi-structured interview where I'm
Hmm.
teasing out their occupational profile.
Hmm.
Okay, so I want to know, what they did. What did they do? Because sometimes you use the word occupation and people think, oh, it means your job. No, occupational things is what you do. It's the things that you do
Hmm.
in order to find meaning in your life. And
Hmm.
so during the evaluation, that's when I'm learning, not only am I doing objective stuff as far as, their range of motion and their strength and, sensation, but now I'm also doing like personal stuff, like, what sort of things did you enjoy doing? So
Hmm.
using stuff like the model of occupational therapy, I went to the University of Illinois, Chicago, and Gary Kilhoffner was
Hmm.
a very big name in occupational therapy and a
Hmm.
very big professor for me at UIC, and he had his model, which is a model of human occupation, and it really teased out like trying to find and identify those occupations that people find meaningful and purposeful in their lives. And so with me having that type of background and learning from that school, that's the goal that I have, particularly is just trying to tease out how to set goals that are meaningful, because meaningful goals,
Hmm.
make it more intrinsically motivating to achieve. Because if I can make a goal for someone to be able to get to the bathroom
Hmm.
independently, but it has to mean something for them. And so
Hmm.
during that evaluation process, it's kind of like a teamwork. I'll ask them like, hey, what do you want to be able to do by the time you leave rehab?
Hmm.
And then in that way, I'll let them tell me, and then basically I'll use that as my blueprint to write goals. And
Hmm.
then as far as them achieving it, I remind them. I say, hey, after 7 days, We're going to see where you are, and then I'm going to write a progress note and see if we might need to upgrade the goal or we might have to downgrade the goal depending on progress. So,
Absolutely. Absolutely.
okay.
I agree. Mm-hmm.
Can you discuss some common misconceptions about occupational therapy
It's a lot of those.
and your respective specialty areas? Okay, so some common misconceptions. I'm sure you heard a bunch of them,
I
Shirley.
heard a lot of them. Well, I would definitely say
So
this.
many.
Occupational therapy, first of all, they think that occupational therapy means what? You getting me a job. They thinking occupational. But it's really occupying your time with day-to-day activities. The other misconception is that we play with a lot of toys.
Oh my goodness.
But I tell patients, I say these different activities that we use are helping you reach a goal. You may not see that, but they are. So because we use a lot of different activities and games, depending on what things we're working on, one misconception is that we're working on a lot of treatment toys and playing in occupational therapy. It's not until they have a disability or deficit that they realize, oh, okay, these clothespins I can actually reach. Before they were at 90 degrees, but now I can reach high enough to reach the back of my head to comb and brush my hair. So that's the purpose of it. But a lot of times, patients as well as family members, they don't see the importance of using those activities. We know why we're using them. So those are two misconceptions that I've heard over the years. What about you, Julie?
Big one. OT takes from the waist up. PT takes from the waist down.
Absolutely.
So, and that is really, something, because again, and Shirley knows, as far as an outpatient, PTs work on shoulder stuff, and OTs work on mobility. We
overlap. we overlap. Some things we overlap as a profession. I'm sorry for cutting you off, but
So there's a result, because I know when the doctors sometimes say, hey, I want to know how this person is mobilizing. Well, guess what? The person has to go to the bathroom. I mean, so OTs, as I go up on acute care floors, I bring my walker with me, and I take a walker and I say, hey, you know what? We're going to mobilize you to the washroom. Before I came down here, I was working with a laminectomy, and he said, well, you're the occupational therapy. You work on my hands and stuff. And I said, yeah, if you want to, do that one little 2% of what I do. But I mean, yeah, I'm more than that. So yeah, so I helped him get up. His son was right there. And this person who was in a lot of pain, because he's one day post-op. And sure enough, I got him up, and he was a bigger, stockier dude. And he was floored how easy he transitioned to a sitting position without much pain. And I said, yeah, it's just not PT that can mobilize patients. We too can do it. The other thing is, I had a nurse maybe a couple weeks ago who said, well, OTs, you guys do the feeding and zippers and buttons. And I'm like, yeah, again, if you want to get me to the minutia of 1% of something I do, it's just so much more. And so
there's so much more
to it. And then we're not even talking about settings from, if we think about OT and psychology or on the mental health floors, there's so much more that they do, because OT can go down to mental health floors and run groups and do a lot of purposeful and meaningful things there too, as well as the schools as well. So there's a lot there.
As some of it, just to piggyback, you're right, the specialty areas. Some of the areas that talk about the areas that our professions are in, that we work in.
And so in those different areas, I mean, there's so much, because to me in schools, OT is the king over PT, because some of the fact that OT does a lot of stuff with handwriting, does a lot of stuff with
Absolutely.
behavioral programs and stuff like that. So where
Mhm.
PT is more, they seem like PT is more limited towards the real physically challenged students,
Students. Mhm.
where OT can go into a learning disability class, go into a behavior disorder class, and actually work and help the special ed teacher or help the case manager to come up with real strong goals for the IEP.
Mhm.
So that's where I think misconceptions can be turned into educatable moments if you were to ask the occupational therapists what they did, and you'll
Yeah.
get the full landscape of what we do.
Yeah,
So
because they do. They put us in this small box
correct.
as to only
Mhm.
working in areas like hospitals. We're in the school system.
Correct.
Okay, we're in nursing homes, rehab units.
Right.
Okay,
I
home care.
I
I've done
right.
home
Correct.
care.
Correct. All done home
Mm-hmm.
care. Yeah, that's right.
Mm-hmm.
Or even
Okay.
I know
And like you
OT.
say, mental health facilities.
Fortune 500 companies. I've seen OTs
See?
who work
Uh-huh.
with ergonomics. They go in and help their
Absolutely.
employees set up their work environment, so prevent
Work
carpal tunnel.
capacity.
Yep, exactly, work capacity. So there's
Mhm.
a lot that occupational therapy does do and can be very beneficial for society as a whole. So,
And that's one of the biggest
mhm,
misconception
mhm,
is
mhm.
the areas that we work into.
Correct.
Hmm.
So yeah,
And I just want to piggyback on something too.
go ahead.
I told a patient, I had a stroke patient many moons ago, many years ago, and the patient was like, I just want to walk. I just want to walk.
Correct.
But he couldn't dress himself.
Correct.
I said, what if you're at home?
Right.
You can walk,
Mhm.
but you can't even put on your clothes to open the door
Correct.
to see your family. You know, you need to be able to dress yourself before you start walking.
Right.
And so that's why I told them some of those things are important. I
Right.
just wanted to state
Right.
that.
And that's also the area that occupational therapy does have over certain other therapies, is the fact that it's that cognitive piece that we could sit back there and say like, hey, you know, besides the physical aspect of it, there's
Absolutely.
that insight, that judgment that's
Hmm.
missing, that in which occupational therapy can address, to say, yeah, you have to have a little bit more insight to your day-to-day functions. Because if
Absolutely.
you can walk, yeah, you can walk, but you also can walk and burn a house down. You can,
You're not safe.
you're not safe.
We look at safety in the homes.
Correct. Safety.
Hmm.
Safety is
Hmm.
huge. And
Hmm.
especially if you might have a dementia patient, in which we do work a lot with dementia as well,
Absolutely.
who they can
Absolutely.
walk. But boy, if they
Hmm.
walk and they get outside, oh my God. So,
Hmm.
so OT does work with that, particularly in home health, where we will do some education as far as safety in the house, and also just orientation to reality on a regular basis.
And a lot of times, what we say in our profession is OT look at the whole person,
Correct.
okay?
Correct.
Not just one part.
Correct.
So we're looking at the mental as well as the physical.
Correct. I
Hmm.
agree wholeheartedly.
Hmm.
Okay, Shirley, can you provide some examples of innovative treatment techniques or interventions that are particularly effective in your specialty area?
Okay.
Innovative or techniques that you might have used that seem like was very effective, real.
I use a technique, and you've used it before too. Myofascial
Mhm,
release
mhm,
is a technique that we're trained to do. I'm not certified
mhm,
in it, but I'm trained. And what that is kind of, I tell people, you have muscles, and in between the muscles, you have fascia. And that fascia in between those muscles can create some pain.
mhm.
And in your arm, leg, back, neck, whatever. And I say, think about chicken. I'll give you an
Yeah, that's right.
example.
That's right.
Uh-huh. The fascia is like the skin. Okay, you take the skin off the chicken and you see that thin layer.
Mhm,
That's the fascia, just like on that chicken. Okay. But what's happening is sometimes it's rubbing together, as I mentioned, and it creates pain. So when you do a myofascia technique, you helping to relieve that pain by putting a stretch on those muscles. So that's one technique I love using. Like you, I know you're certified in taping. I use the taping technique a lot
Mhm.
on patients with carpal tunnel that have wrist pain.
Right.
Okay, I use it on my hand patients with Decker veins
Mhm.
that have pain along their thumb area because of that injury. And again, like the shoulder patients, some of our pain patients. And E-stim.
Oh yes.
E-stim is very good in achieving. So those are some of the modalities and techniques I like and enjoy using. But there's also more.
Right.
Hmm.
Well, one thing that I could say that I really enjoy now, this is I'm not going to plug another hospital, but when I worked
Hmm.
prior before I came to Mercy, I was employed in another hospital, and they would bring NDT course, which is neurodevelopmental treatment
Uh-huh.
or
Yeah.
therapy. Um, the person will travel she come all the way from California, San Jose, California. I think that's where you have to go get
Mm.
the NDT certification at. But
Okay.
she came and she did like I want to say 4-day course
Hmm.
on how to use these techniques in order to do sitting, positioning, handling of patients.
Mm.
And all you needed, your fingertips.
Your
So
hands.
yeah, your
Hmm.
hands was
Hmm.
really important. You had to really know your muscles. You had to know your insertions, your origins, and stuff like that. How to facilitate or inhibit those muscles.
Hmm. That's like
Those,
back in the day.
yes, that course, and going back to that question about advice for young therapists. I would tell young therapists to find that course and take it.
Hmm.
NDT course, if whenever it comes to Chicago, and I hope maybe one day this hospital might be able to host one because I think that would be
Hmm.
really good.
Hmm.
It is a great course because it teaches you how to handle patients, big, small, pusher syndrome,
Hmm.
whatever.
Hmm.
It's a very good course. And so that alone is like one of the bases of my treatments. I'm very much a mat table, get in their space
Hmm.
type of therapist.
Hmm.
And so if I see someone who has poor posture, who has maybe a lateral lean with pushing and stuff like that, I'm getting in and I'm using those techniques. Not
Hmm.
only am I using those techniques, but I'm also using equipment,
Hmm.
balls,
Hmm.
bolsters,
That's what I
things,
still use.
yes,
Hmm.
kickboards,
Hmm.
those things that allow the person to get back into a
Hmm.
normal pelvic tilt versus like a posterior pelvic tilt where they're got rounded back
Hmm.
and stuff like that. I'm
Hmm.
using those and using my fingertips to facilitate and get that patient to sit more
Hmm.
upright, get them more midline.
Hmm. Hmm.
And I really do feel like it's kind of like an oldie but goodie, and it evolves because whenever her name is Kathy Runyon, she's probably been a therapist for over 40 some years, but
Hmm.
she's very good. And I was a doubting Thomas, and when I was at the other hospital that I worked at, she made me come to the front of the class. And this woman might be 130 pounds, maybe 5'5", not a big woman at all. And I'm
Hmm.
not like a big guy, but I'm a solid dude.
Yeah, you're
She
muscular.
so she had me sit down
Hmm.
and she said, try to resist her as she's trying to attempt me to get into a squat position. And I did. I sat down, locked myself up, and she used her fingertips and she used her knees to kind of be at my tibialis anterior, and she lifted me off and actually moved me from side to side in a squat position as I'm trying to, and she kept telling me try to sit down. I could not move. And she used NDT techniques,
She's strong.
in order to do it, her fingertips. And I think that that's a good way. So now when I do anything I do with patients and I have to really get in their space, I'm using those techniques. And I think that they're very, really good. And like I said, my advice for younger therapists, even PTs, OTs, take one of those courses. It will change your therapeutic life.
And I tell young therapists, I tell them, while you taking your clinicals and you decide once you pass your clinicals
Mhm.
and become an OT, all new therapists need to work in rehab first.
Oh yes.
Rehab
Oh
is the
yeah.
foundation
Oh yeah.
for you learning how to work in acute,
Yeah.
outpatient,
Right.
anything.
Right.
Rehab is the foundation. Start with a rehab facility or a rehab
Correct.
unit
Mm-hmm.
because you will learn a lot about the patient, their disabilities, the deficit areas.
Hmm.
Very important.
Right. Time
That's what I,
management. Yes.
yes,
Time is it because
yes,
again,
everything.
rehab is it churns. I mean, it's like
Yeah.
you got a patient every 45 minutes is different, or an
Mm-hmm.
hour and a half, or whatever the
Mm-hmm.
case is. It teaches you how to
Mm-hmm.
learn to manage your time, as well as keep your mind um, interested in the different patients you're going to have, because you might
Mm-hmm.
have somebody who's very motivated and might have a hip replacement or whatever, and kind of high level patient. Then you might have a low level patient who might have a brain injury or some
Mm-hmm.
underlying cog issues where you really have to work. So so it keeps the
Mm-hmm.
brain innovated, just to
Mm-hmm.
say, how can
Absolutely.
I deal with this? And so
Mm-hmm.
I agree with Shirley. Definitely, for those young therapists, get some rehab experience
Get
first
that rehab
before you
experience
decide to,
first.
Go over to a nursing home or go to,
Absolutely.
schools or whatever. So yeah, I 100% agree with that. Yes.
I have a question for you,
Mm-hmm.
Julian.
Yes, ma'am.
What schools in Chicago have OT programs?
Okay. Chicago State.
I actually graduated from
Okay.
Chicago
Okay.
State
Okay.
University in 1991.
Beautiful job. Okay. And
Mhm.
UIC, where University of Illinois Chicago,
Mhm.
I am a graduate,
Absolutely.
2005.
Hmm.
Um,
Oh,
um,
okay.
uh,
Congratulations. Okay.
Rush
Hmm.
University,
Okay.
Governor State University,
Hmm.
Midwestern University in Downers Grove.
And Wright College, right? Is it Wright
That's
College? Is
a
it right?
COT program.
COT,
So
yeah.
so
So to,
so to explain to what a
okay, okay. There's an
mhm,
occupational therapist. We
mhm,
have a certified occupational
correct.
therapist,
Hmm.
and that's a 2-year program.
Hmm.
And we also have certified, I'm sorry, occupation, a registered occupational therapist license, an
Hmm.
OTR. And that's a 4-year program, but also it's a MD program
Correct.
too,
Hmm.
correct?
Yes,
They have to
OTD
go.
program.
Okay, you could explain a little more about that.
Okay, well,
Uh-huh.
basically, schools, you know what? Unfortunately, the bar keeps becoming raised. It's like the brass ring comes a little higher. So, like
Mhm.
physical therapy, I believe there's no physical therapist that's practicing that doesn't have a doctorate degree. So that
Absolutely.
program changed. The field of occupational therapy, the professional occupational therapy, also decided to raise the
Mhm.
requirements, and so as a result, they adapted the OTD program, which is Occupational Doctorate
The doctorate
Program. And so,
program now.
so I believe
Hmm.
places like Rush and Midwestern University,
Hmm.
anybody who gets into their program, they're going to the OTD program.
Okay.
UIC has it's an option. You can still get a master's and be a
Hmm.
practicing therapist,
Therapist.
but
Hmm.
there's an option to do more research in order to get the OTD program. So I believe it's either it's extra year and a lot of
Hmm.
intensive research in order
Hmm.
to get the OTD program. So or to get that particular
Hmm.
designation. So, but that does not mean that the the doctorate level therapists have any
More
more advantage over
experience.
than
Hmm.
someone who gets a master's. It's just that they decided to go that route, and maybe they want to teach at the university level. So so they
Hmm.
can do that.
Hmm.
Uh, but but well, let
Yeah,
me ask you
because
this, Shirley. Go ahead.
I have a 4-year program. I have a bachelor's
Mhm.
you know, and it was a 4-year program when
Mhm.
I was attending Chicago State,
Okay.
and they were talking about making
Correct.
it a
And
master's
that's
program.
and that's
Hmm.
how the profession
Hmm.
has evolved. It went from, a 4-year
That is.
bachelor to
Hmm.
now, like, then it was like, okay, well,
Hmm.
people who are practicing need a master's degree, and then that's the program that I came from. And
Hmm.
then eventually I'm hearing the scuttlebutt is eventually it will be raised all the way to all OTs will need the OTD,
OTD.
so the
Hmm.
doctorate level. But
Oh,
right now,
really?
there's still some schools that, and the profession
Have
has
the
not
masters.
100% said that,
Hmm.
that you have to have a doctorate degree, because again, it raises the bar up, and then, that's extra schooling, which is extra money and stuff
Hmm.
like that.
Yeah,
So,
absolutely.
so we're all, so Shirley and I are already kind of grandfathered in, so we're good, and
Absolutely.
in our experience kind of does a
Speaks for itself.
correct. And then Shirley, so what's the difference between what
Hmm.
can a certified occupational therapy assistant do versus what a registered OT can do?
Okay. Certified occupational therapy assistant, they do mainly treatments, whereas the certified occupational therapist, licensed therapists, they do evaluations and
Correct.
treatments. That's the difference. Okay.
Mhm.
So I can evaluate a patient and follow up on the treatment. But with the certified occupational therapist, because it's a 2-year program, we would complete the evals and they would follow up on the treatment on the patient.
Mhm.
Okay. And you want to add to that,
Yeah,
other
yeah,
than what
yeah.
I've said, you know?
Yeah, well, you know what?
Hmm.
I've worked shoulder to shoulder
Hmm.
with CODAs, which is acronym for a Certified Occupational Therapy Assistant,
Hmm.
um, for years, and even to this day, we have a very good one here at Insight Chicago, um,
Hmm.
and I feel like her clinical knowledge is so strong, on top of the
It
fact that
is.
you know um,
Mhm.
some might have some really good experience. Our particular one used to be a CNA, so when
Hmm.
it comes to the compassion and when it comes to the hands-on handling of a patient in their hospital room,
Hmm.
she's so good because she infuses her CNA experiences in with her therapy experiences, which
Hmm.
makes her like top notch as far as
Hmm.
just like hands on, get in there,
Hmm.
and really work with the patient. So that's a plus. They can go to continuing ed courses as well as
Hmm.
an occupational therapist, a registered person, and they can learn and enhance their skills as well. So
Hmm.
coders can go to
Hmm.
courses in which they can become certified stroke specialists. They can
Absolutely.
become lymphedema certified. Is that correct?
Certified,
Yep, they can get
certified
kinesio.
lymphedema therapy,
Yeah,
CLT.
right,
Hmm.
CLT. So they
Hmm.
can they too also can advance their professional knowledge as well. So they're not limited to that. They
Hmm.
can do e-stem, so they can do all the things with the exception, as Shirley mentioned, the
Hmm.
evaluation process. We do
Absolutely.
the evaluation and we do the discharging.
Hmm.
But yeah, I think as far as for OT month, I always want to make sure that they are recognized because they're
Absolutely.
strong. They're very good
And
therapists.
a big part of our profession,
Oh my goodness, yes.
we work together, and so
Mhm.
I was going to end it.
Okay, okay.
If well, if
Yeah,
you
I
had
agree.
one other question, I just wanted to say thank you for giving us this opportunity.
Okay. Well,
Oh,
let's end it on this last question because
okay,
this is
well,
and actually the last question of the day. Okay.
okay, we'll end it on this last
How
question.
can the public and other healthcare practitioners better understand and support the valuable work of occupational therapy across various specialty areas? So how can, we make the public understand us and what we do?
By educating them. Education is the key. We are constantly educating
Mhm.
people, even doctors,
Mhm.
about our
Right.
profession.
Oh yeah.
Okay. So
Mhm.
I would say educating. educating them, and just like with doctors, letting them know the importance of OT in the areas that we cover, our specialty areas in the hospital, and how it's important to refer patients, especially with hand injuries, strokes, and acute care. We are working with some of the same diagnoses that PT working with, with the exception of back and leg injuries.
But we do back. We do some laminectomies.
Well, we do laminectomies.
Yeah, we do. Certainly do.
Well, in terms of doing outpatient treatment with back and neck, I guess I'm thinking about outpatient treatment and how we defer in terms of that. But knowing that we are constantly educating the public, their families, people on the street, we're constantly educating about our profession and the importance of having occupational therapy and needing it. That's pretty much what my take on it is. Education is the number one key to understanding our profession. And we can also, just like we did on the second floor, educate people by having, seminars and things like that.
And you know what? And also having a supportive hospital that recognizes the valuable contribution that all healthcare practitioners give to it, because I think that's so crucial. Is that professions are recognized for their contribution. So this is OT month, so I'm happy that Insight is taking time to recognize us and make us feel it's our time, and they're saying, hey, you know what, we recognize that and we're going to give you this platform. So thank you, Insight, for allowing OT, because again, this is our time to shine, and we really do appreciate that, because that helps to let others know, particularly our own colleagues and stuff like that, to know that this is a very powerful therapy that's very important to necessary and to the well-being of people getting better. So thank you, Insight, for taking time and allowing us to talk with you guys, as well as share this platform to others. So thank you.
Yeah, it's a very important profession, and a lot of times it's not recognized as one, and it is just important as PT. And I would say, if you're unsure and not aware what OT is and what it does, educate yourself and ask a professional, or look it up, research it yourself.
Correct.
And you'll find out, we're very valuable to the profession.
That's right.
And Julian, one other question. Is it any other certification you're pursuing or thinking about?
Yeah, there's quite a few, actually.
Oh, really?
I do. I would love to get what's called the Power certification, which is actually a certification for people who have Parkinson's disease. So I would love to get that. And maybe, I don't know, I'm thinking about lymphedema. I'm not sure.
Okay, you should.
I mean, it's interesting.
That's how I actually got in. I was interested in it, and then I took the lymphedema course, and we had to pass it and get certified and that type of thing. Right. But mine is CHT. I'm thinking in the next 2 years to be a certified hand therapist. It is. I've been practicing, like I said, for 30 years, hand therapy, because that VA hospital was my first introduction to hand therapy, because we actually had a hand clinic. So, and I love making splints and braces. So those are things we're gonna constantly pursue in our future.
Yes, right. That's right. That's right. That's right.
But yes, thank you for this opportunity.
Please, thank you. We're very, very humbled by this opportunity. Thank you for recognizing occupational therapy.
Yes, thank you.